Hello everyone, Dr. Kofi here, and welcome to another episode on TutorMed, where everything medicine is simplified. In today's video, we will have a tutorial in pediatrics and we will discuss a clinical case. And so if you are preparing for any licensure exam and you are new here, you want to consider subscribing to the channel and then putting us on post notification so that you will be updated on any new video uploads. Thanks for doing that. Alright guys, grab your notepads and let's begin. And so straight to our clinical case. We have a 4-day-old neonate who presents to your consulting room with yellowish discoloration of the sclera and the skin. Now there are 4 questions to this clinical case. The first is, what is your diagnosis, and give 3 differential diagnoses. Okay, so a few seconds to think through this clinical case. Very well. And so for this clinical case, the relevant information are the fact that we have a 4-day-old neonate who presents with yellowish discoloration of the sclera and the skin. And so for our diagnosis, the diagnosis is likely to be neonatal jaundice, specifically the physiological one, physiological jaundice of the newborn. More recently, a better term is a benign neonatal hyperbilirubinemia. And then for our differential diagnosis, we have neonatal jaundice secondary to a hemolytic disease like hemolysis from G6PD full defect, blood group incompatibility like ABO incompatibility. And then the second differential we are entertaining is neonatal jaundice secondary to sepsis. It can also be due to neonatal jaundice from a breastmilk jaundice. We have several other differentials you can think about, like breastfeeding jaundice, neonatal hepatitis, etc. Now let's spend a few moments discussing neonatal jaundice, what it is, and then the various differentials. Neonatal jaundice, or icterus neonatorum, is caused by elevation of a chemical in the blood known as bilirubin. Now, as you may be aware, bilirubin can exist as unconjugated bilirubin or conjugated bilirubin. And so, based on which pigment is elevated, neonatal jaundice can be classified as either an unconjugated hyperbilirubinemia or a conjugated hyperbilirubinemia. In certain instances, we have a mixed picture, and so we have a mixed hyperbilirubinemia. And it can also be classified based on whether the cause is physiological or pathological. And so we can have physiological jaundice or pathological jaundice. Now back to the unconjugated and conjugated hyperbilirubinemia. The fear with the unconjugated hyperbilirubinemia is that when the unconjugated bilirubin exceeds levels which are neurotoxic, they can harm the brain, and so there is a need for a swift response. Elevated conjugated bilirubin might not harm the brain, but when it is elevated, it may be an indicator of a liver damage or a systemic illness. And so let's take a look at what physiological jaundice is. Benign neonatal hyperbilirubinemia. Now, physiological jaundice usually begins on the 2nd day, and then by day 7, it usually resolves. Now, about 60 to 70% of term neonates develop physiological jaundice, and about 70 to 80% of preterm neonates also develop physiological jaundice. And so what are the reasons to explain this physiological jaundice? Jaundice which is of normal occurrence. First, newborns have more red blood cell mass or more red blood cell number compared to adults. And in addition to this, these blood cells have a shorter lifespan, and so they hemolyze faster. Again, after birth, these surplus red blood cells are broken down, increasing the bilirubin levels. And so it is physiological for a newborn to have high bilirubin levels. Then the second reason is that the bilirubin clearance in newborns is decreased, especially for preterms. The liver and its enzyme system are responsible for bilirubin clearance, that is to conjugate it and to excrete it. And so in newborns, it is the liver and then the enzyme system is not very developed, and so its underdevelopment leads to accumulation of bilirubin in circulation, causing the jaundice. Then the third reason is that there is an increased enterohepatic circulation of bilirubin. Enterohepatic circulation means that the bilirubin, which has been conjugated by the liver and it has been sent into the gut, is deconjugated and then sent back into the blood, into the liver. So that we have an increased enterohepatic circulation. And then this is partly explained by the fact that in neonates, the bacteria which are supposed to convert the bilirubin into a non-reabsorbable form is not present because they have not colonized the gut yet because of their early life on Earth. And so an increased enterohepatic circulation of bilirubin because of low levels of bacteria also explains the reason why neonates may have a physiological jaundice. It is not the entire explanation, but partly the explanation. And so if the jaundice is not physiological, then it is pathological. It means most likely there is an underlying pathological process which is leading to the elevated levels of bilirubin. And so neonatal jaundice is considered pathological if the timing of the appearance of the jaundice, the duration of the jaundice, or the pattern varies significantly from the features of physiological jaundice. And so, for example, the timing of physiological jaundice is usually from the second or the third day. And so if you have jaundice appearing at birth or within 24 hours of birth, then we need to suspect a pathological jaundice. And we said that usually physiological jaundice ends by day 10. Some may extend to day 14. But if you have jaundice lasting more than 2 weeks, otherwise known as prolonged jaundice, then we have a reason to suspect a pathological jaundice. Then you have jaundice associated with symptoms and signs. You have a patient with jaundice who has fever. The patient is lethargic. The patient is having seizures. Then there is a cause to suspect a pathological jaundice. Very good. And so please do not forget to like and share this video and subscribe to our channel if you have not done that yet to support us. Thank you for doing that. Now on this slide, let's look at some causes of unconjugated hyperbilirubinemia. What would cause the unconjugated bilirubin to go up and then cause jaundice? Now, the unconjugated bilirubin is produced from the breakdown of worn out red blood cells, and then when they get into circulation, they need to be picked up from the circulation by the liver. It means that if you have unconjugated bilirubin high in the blood, it's either we are producing them too much from the red blood cells, or the liver, which is supposed to pick them up from circulation, is not doing its job efficiently. And so for the increased production, it could come from hemolytic processes. Example, from rhesus incompatibility. Now, if the mother is rhesus negative and the baby is rhesus positive, the jaundice can occur within the first day of life. A reason why infants of rhesus negative mothers are sent to the NICU to be monitored for the first 24 hours. Now, another cause of the hemolytic process is ABO incompatibility. If the mother is blood group O, remember that any patient with blood group O has antibodies against A and B antigens. And so if the baby coming is blood group A or B and it's not O, there may be a mild degree of hemolysis, and this will cause jaundice. Now, the jaundice from ABO incompatibility is milder than the jaundice of rhesus incompatibility. The reason lies in the difference between the antibodies for each of them. The antibody which is responsible for the ABO incompatibility is IgM, while the antibody which is responsible for the rhesus incompatibility is IgG. Now, IgM rarely crosses the placenta, but sometimes it crosses and it might cause mild hemolysis. However, IgG can cross the placenta and then start the hemolysis very faster. That is why the jaundice from rhesus incompatibility is severe. more severe than ABO. Now, other causes of hemolysis include G6PD full defect. Now, I want to highlight some other causes of increased production of bilirubin. We have a patient with polycythemia. If you have an increased red cell mass, it means we are going to break a lot of red cells, and we are going to result, or we are going to produce plenty unconjugated bilirubin. Then we have extravasation of blood into tissues. You have a patient who has cephal hematoma, birth injury. We will break that red blood cell which has collected, and it will result in jaundice. And then we have decreased bilirubin excretion. So especially in premature infants or neonates, their liver system or their enzyme system is not really developed, and so they can't pick the bilirubin from the blood. So we have jaundice. Very good. And so now let's see a table showing the causes of the conjugated type of hyperbilirubinemia. Now, there are several causes of conjugated hyperbilirubinemia, and this table illustrates that. However, the cause could be a problem in the liver, or the problem can be in the duct or the channel which drains the bile or the bilirubin out of the liver, and so extrahepatic. For the intrahepatic causes, common ones include neonatal hepatitis from hepatitis B infection, or the TucherMed infection, the congenital infections that can happen during pregnancy. TucherMed, so T for toxoplasmosis, TO for toxoplasmosis, then R for rubella, C for cytomegalovirus, and then HS for herpes simplex. And then for the post-hepatic causes, the significant one I want to point out is biliary atresia, where the biliary drainage did not canalize, and so when the liver conjugates the bilirubin can't get out of the liver into the gut, leading to accumulation of conjugated bilirubin, causing conjugated hyperbilirubinemia. Very good. Now let me use this slide to distinguish between breastfeeding jaundice and breast milk jaundice. Now, in breastfeeding jaundice, this type of jaundice develops in 1/6 of all breastfed infants, especially during the first week of their life. Breastfeeding increases the enterohepatic circulation in some infants, some of the infants who are breastfed, who have decreased milk intake. They are not feeding very well. And so because they are not feeding very well, the gut is not able to be mobile. And so it makes the feed stay longer in the gut and gives time for the bilirubin to be deconjugated. And then when they are deconjugated, the gut can reabsorb them into circulation. And also, children who have this problem, the decreased milk intake, and are also dehydrated, or they have low caloric intake. It is the same explanation I've given. And then we have breast milk jaundice. Now, breast milk jaundice develops after the first 5 to 7 days of life, and it peaks at about 2 weeks. Breast milk jaundice is thought to be caused by increased concentration. There is an enzyme in the breast milk known as beta-glucuronidase. Now, this enzyme can deconjugate the bilirubin already conjugated in the liver, can deconjugate it, and once bilirubin is deconjugated, the gut is able to reabsorb it, and then increasing the enterohepatic circulation. And so breast milk jaundice is thought to occur because beta-glucuronidase, an enzyme in the breast milk, is able to deconjugate the bilirubin in the gut, thereby causing the gut to absorb the unconjugated type. Very good. And so the second question says, what 4 investigations will you request for? Now, one of the initial investigations you need to request for is total serum bilirubin and then direct bilirubin. Why? Because you first need to establish that there is hyperbilirubinemia, and so an elevated total serum bilirubin will tell you that. Then after you've known that there is hyperbilirubinemia, you need to know the type, whether it is conjugated or unconjugated. And so if the direct bilirubin is at least 20% of the total, then you have a conjugated hyperbilirubinemia. Then the second investigation you wish to do is to know the blood group and rhesus status of the mother and then the child. This is to identify any ABO incompatibility or a rhesus incompatibility. Then another investigation you want to do is the coomb'stest. For the coomb'stest, we have two types. We have the direct coomb'stest and the indirect coomb'stest. Now, the purpose of the direct coomb'stest is to detect antibodies which are bound to the baby's red blood cells. And so direct coomb'stest is for the baby. And so if the direct coomb'stest is positive for the neonate, it means that the red blood cells have been bound to some antibodies which are likely from the mother, indicating an immune-mediated hemolysis. It could be from rhesus or ABO incompatibility. While the indirect coomb'stest is for the mother, it detects antibodies in the mother. Then we can also do G6PD enzyme assay to detect if there is any G6PD fold defect. And so yes, 4 investigations, but other investigations we can do include a full blood count, which can tell us whether there is anemia. We can do reticulocyte count, which when increased can tell us that there is hemolysis. We can do a septic workup, including a urine culture and then a blood culture. We can do liver function tests. We can do serology to test for the touches, toxo, rubella, cytomegalovirus, herpes simplex. We can do thyroid function tests, a number of them, depending on the clinical presentation. Now, the third question says, mention 2 complications of the condition. So for this baby, the complications that can arise include 1. Cerebral palsy. 2. A sensory neural hearing loss or deafness. So we've mentioned 2 complications and that is enough. But it is important to know that there are other complications like mental retardation. And so now let's take a brief moment talking about how the complications develop. Very briefly. Now, the complications of neonatal jaundice are mainly a consequence of severe unconjugated hyperbilirubinemia. Now, unconjugated bilirubin is a lipid-soluble molecule which functions as an antioxidant, and so it is not a bad molecule. However, elevated levels is a problem. Now, being a lipid-soluble molecule, unconjugated bilirubin can cross the blood-brain barrier of neonates and cause a spectrum of neurotoxic injuries called BIND, bind, which stands for bilirubin-induced neurologic disorders. Now, when neurotoxic levels of unconjugated bilirubin crosses the blood-brain barrier, it binds to brain tissue and causes death. Now, there are certain sites in the brain which mainly suffers this injury. They are 1. The basal ganglia, and so the caudate, the putamen, the globus pallidus. Then the brainstem nuclei. 4. Cranial nerve 3, oculomotor nerve, and then cranial nerve 7, auditory nerve. And then these injuries explains the clinical features of bind that we will look at later in a second. Now we can have acute and then chronic bilirubin-induced brain damage or encephalopathy. And so briefly, let's look at the acute type. And so acute bilirubin encephalopathy or encephalopathy. Now, the clinical features may be described in 3 domains. We look at the child's mental status, the child's cry pattern, and the tone. And then typically, acute bilirubin encephalopathy has an early stage, an intermediate stage, and then an advanced stage. And so for the early stage, when we look at the mental status of the child will be sleepy but very arousable. Then we look at the cry pattern. The child would have a high-pitched cry. Then we assess the tone. There will be a mild to moderate hypotonia. And fortunately, this stage is reversible or may be reversible. Then as the condition progresses to the intermediate stage, when you assess the child's mental status, you'd realize that the child will be lethargic with a poor suck when feeding, or interestingly, the child may be irritable with a strong suck. You check the cry pattern, the child still has a high-pitched cry. Then the tone, you would see that the child has a back arching of the neck and the trunk when stimulated. The picture in the next slide will illustrate this position or this tone. And so this is a picture showing the back arching of the neck and the trunk. Now when the neonate is stimulated, for example by flickering the sole of his foot, the baby may arch his neck backwards, and this is called retrocollis. Retro means back, collis is a term for the neck. Then again, he will arch his trunk backwards, and this is called opisthotonus. And so this is a very significant indication for an increased tone. And so the acute form progresses to the advanced stage if no intervention is put in place. And here in the advanced stage, you check the mental state of the child. The child may be semi-conscious or comatose. You check the cry pattern. The child would have an inconsolable cry. The cry may be weak or even absent. Then you check the tone. You may have, or there is persistent retrocollis and opisthotonus. Other features in the advanced stage include fever, seizure, and then inability to feed. And these patients may die from respiratory arrest because of the repeated seizures or repeated aspirations. Now, children or neonates who survive the acute stage go on to have the chronic bilirubin encephalopathy, pathologically known as kernicterus. Now, the damage to the basal ganglia usually gives a chorioarthitoid cerebral palsy. There are other forms of cerebral palsy, like the spastic quadriplegic cerebral palsy. But the chorioarthitoid cerebral palsy, that's where the chorioarthitoid means that the damage is to the basal ganglia. Then, the damage to the brainstem nuclei for auditory nerve results in a sensory neural hearing loss, and so this explains why. And then, damage to the brainstem nuclei for the oculomotor nerve results in gaze palsies. The child may have some palsies when he's gazing at something. Then, we look at the last question. The last question is, how will you manage this patient? And so for this patient, you manage the jaundice with phototherapy or exchange transfusion depending on the severity of the jaundice and the level of the total serum bilirubin. And then you treat any treatable underlying cause. If there is sepsis, you need to treat the sepsis. And so thank you for watching this episode, and kindly like and share our video, subscribe to the channel, and thank you for subscribing to our channel. All those who have done that, thank you for supporting us. Thank you for liking and sharing our videos. So until we meet in our next video, bye.